So with the next presentation with Dr. Samer Koussaher, spinal cord ischemia after TIVA, how to prevent it.
Good morning, everyone. First of all, I'd like to thank Professor Suleiman for his invitations. I'm going to speak about spinal cord ischemia after TIVA, how we can prevent it. Spinal cord ischemia receives blood from a lot of branches. So it's very extensive blood supply. It usually comes from the vertebral artery and ascending cervical artery, which is both coming from subclavian artery. It has a posterior intercostal artery from the thoracic aorta, lumbar artery from the abdominal aorta, and lateral sacral artery come from the internal iliac arteries. But the most important is the artery of Adama-Weeks, which is supplies the thoracolumbar region below T9, which is called watershed region, and the majority, 75%, comes from T9 to T12, 15% from T8 to L3, and less than 10% from L1, L2. The good thing about spinal cord, it has an extensive collateral network around the spinal canal, paravertebral tissue, and paraspinal muscle. And the reason why when we cover the spinal cord, the majority of patients do well because it's extensive collateral network. But the spinal cord ischemia is still the most devastating complication after TIVA. And unfortunately, even with the endovascular technique, still the incidence about 2 to 10% after TIVA. We have two kinds of spinal cord ischemia, either immediate after surgery, secondary of hypoperfusion, secondary hypoxia damage, or delay happen after 1 to 21 days, and usually as a result of reperfusion, hyperemia, and free radical generation, edema of the cord, and regional hypoperfusions. So what are the risk factors associated with the CSI in the TIVA? First, the length of the operation, the longer of surgery takes a higher incidence of ischemia, perioperative hypotension, indication for intervention. If we do it for emergency, the CSI is about 16% compared with the 4% for elective. If you do it for acute, like a rupture or dissection, the risk is much higher. Female gender is a risk factor. If you have inadequate collateral circulation because left subclavian artery or internal iliac artery occlusion or prior AAA. And the most important is the extension of coverage, especially if you cover T8 to T12. And this is a very nice paper. You look at that. They look at the incidence of CSI according to the Crawford classification. They found the highest incidence when we do it for type 2 Crawford classification, the less incidence when you do it for type 4 because the extension of the coverage. Also, this paper, they look at the CSI related to the indication of intervention, and they found the incidence is lower when you do it for aneurysm and highest when you do it for dissection. The other things that when you're dealing with a TIVAR, especially when you do like complicated one like a branch or BVAR, you can use a large femoral sheath. The problem with a large femoral sheath, it can occlude the origin of the internal iliac artery and the common femoral artery, and both can contribute to the ischemia of the spinal cord. So one way to deal with that is to put a reperfusion catheter in the SFA to reperfuse the legs, or to use a conduit where you can pull the catheter inside the large sheath inside the conduit, and this way you don't have to go and cover the origin of internal iliac artery and decrease the incidence of spinal cord ischemia. So how we prevent CSI during the endovascular repair? We have 4 ways. First one is to minimize the spinal cord ischemic time. Second thing, the augmentation of spinal cord reperfusion, increased tolerance to the ischemia, and early detection of spinal cord ischemia. And I'm going to go through each one in details. So how we minimize the spinal cord ischemia? First, by staging the procedure by creating type 3 endoleak. So when we do like a branched TIVAR, we try to leave one branch open, so keep perfusion to the spinal cord. And then we, about 4 to 6 weeks, give sometimes for the collaterals to perform, and then come after 4 weeks to close it. And the second thing, by identifying and avoiding covering the important spinal artery, especially T8 to T12. The second thing is by increasing the tolerance to the ischemia. We have a couple of medications like barbiturate, cortisone, naloxone, and mannitol. All these medications being tested on the open repair, and they have a good result, but none of them being tested in endovascular repair. The third thing, by augmentation of spinal cord perfusion, by maintaining the mean arterial pressure around 8 to 100, at least for 24 to 48 hours, and by replacing the CSF drainage to keep the CSF pressure less than 10. How this one work? We know that spinal perfusion pressure equal to mean arterial pressure minus the CSF pressure. So increasing the mean arterial pressure or decreasing CSF, this will increase your spinal perfusion pressure. And CSF drainage really is the only method supported by randomized evidence and has class 1B indication in the US guidelines and strong recommendation high-risk patient in the European guideline. So when we do CSF, some people do routinely. We prefer to do it electively, especially if we cover thoracic aorta more than 20 centimeters, or we cover the important area T8 to T12. If patient has a prior AAA repair, if we cover left subclavian artery without bypass, or if he already has occluded internal iliac artery. Of course, he develop any sign of symptom, then we have to put CSF drainage. The most important that when you put CSF drainage and send patient to ICU, you have to write the protocol. They have to monitor the patient, but the most important, they have to zero the spinal cord, the catheter to the level of the spine, because the nurse in the ICU got to use to level any central line to the level of the heart. So you have to put it to the level of the spine. You need to keep spinal pressure less than 10, and don't drain more than 24 cc per hour, because you can end with a subarachnoid hematoma or fatal brain herniation. If the CSF turn bloody, you need to turn it off. You need to keep the spinal drainage at least for 48 to 72 hours. So if you come next day, he has no paraplegia, don't take it, because the patient may develop a delay paraplegia. You need to maintain the hemoglobin more than 9 and systolic blood pressure more than 140. Of course, spinal cord ischemia has its own spinal cord drainage. It has its own complication like headache, catheter fracture, the most important intracranial bleeding, and usually patients develop of severe headache or confusion, and sometimes they can go to the coma. So you have also to be careful, and the reason why we don't use it routinely. The fourth way to protect by early detection of the spinal cord ischemia. And they noticed that the earlier you detect the spinal cord ischemia and treated, the higher chance patient will recover. So you have to look at the spinal cord ischemia as like a compartment syndrome. The sooner you fix it and treat it, the higher chance will be recovered. The longer it takes to fix it, patient may not recover. The reason some people, they use intraoperative monitoring by using the MEEP, which is intraoperative motor evoked potential, or the SSAB. Some people use biochemical measurement like CSF lactate level, S100 protein, and NSE concentration. So what the SSAB, it detects the activity in the posterior lateral column of the spinal cord. But the problem, it does not record the anterior spinal cord column, which is important, usually affected by the ischemia. And the second thing, the specificity is very low, with a high false positive, about 67%. The reason why people, they advocate to use the MEEP, which is the motor evoked potential, by measuring the motor response, especially at the level of the muscle, what's called a myogenic MEEP. Some papers, they show that if you use both MEEP and SSAB, then you have about 90% correlation for spinal cord infarction, as well 98% negative predictor value for immediate onset paraplegia. But in practice, really, they found that SSAB is enough alone, and we don't have to do both. So what happens if patient develop a delay paraplegia? Usually, the most important to see if it has a CSF. If it does not have a CSF drainage, you need to put it. If it already has a 1, you have to be sure it's functioning very well. You need to keep it less than 5, keep the saturation more than 95, and hemoglobin more than 10. The prognosis is very bad. If patient develop spinal cord ischemia, the survival after 36 months can go to 36%. So conclusion, CSF remain a major morbidity after TEVAR, although the incidence is less than open repair. High-risk patients include the female, those with a long area of thoracic aortic coverage, the indication for the intervention, prior to repair and left subclavian coverage, careful pre-operative planning with identification of critical area, and staging the procedure is very important, but the most important is prevention. By limiting the length of the coverage, keep mean arterial pressure more than 90, do CSF drainage, keep it less than 10, elective revascularization of left subclavian artery, and staging the procedure. Thank you very much.